Good afternoon, OR Today. Thank you all for participating in today's webinar. We are thrilled with a great turnout today with over 160 attendees registered. OR Today is proud to offer these free webinars as a way to educate and provide valuable information to the perioperative leaders in our industry. We will offer 1 to 2 webinars per month on Thursdays focusing on issues pertinent to the industry. We will always schedule the most sought after and dynamic speakers in the profession. You can view a complete calendar of upcoming events by visiting ortoday.com/webinars. In addition, we are excited to announce our brand new surgical conference called OR Today Live. Together with our official partner, CCI, we will bring together perioperative leaders for a dynamic and intimate event you will not want to miss. It will be held this August in Las Vegas. You can visit www.ortodaylive.com for more information. Okay, a few notes before we begin. Earlier today, a webinar workbook was emailed to pre-registered attendees. If you did not receive a copy, you can download one now by visiting ortoday.com/webinars and selecting today's event. The workbook will serve as a study guide and reference for today's information. During today's webinar, all lines will be muted, but you are encouraged to submit questions during the presentation by using the questions feature on the dashboard on the right-hand side of the screen. If you have difficulty, please email us at webinar@mdpublishing.com. You can obtain a certificate of attendance for your participation by completing the post-webinar survey at the conclusion of today's webinar. This survey will appear immediately on your computer screen. Certificates will be emailed on or before June 25th. If you do not receive the survey, again, email us at webinar@mdpublishing.com. Okay, OR Today would like to thank our sponsor today, Encompass Group. Encompass Group is one of the leading manufacturers and marketers of reusable textiles, professional apparel, disposable and single-use medical products. Encompass Group believes that every patient, resident, caregiver, and family member should feel safe and comfortable in today's healthcare environments. Markets served include acute care, long-term care, senior care, retail healthcare apparel, hospitality, and government operations. Our presenter today is Carol Stamas. Stamas has extensive clinical experience in critical care and nephrology and staff management and education. Her industry experience includes renal clinical research, IV therapy, OR consulting, healthcare textiles utilization, standardization, clinical education on patient warming, skin integrity, anti-embolism, DVT prevention, and patient safety. Carol, you may begin whenever you are ready.
Thank you, John. I am pleased to have the opportunity to present to you our seminar today, Mind the Gap, Raising the Bar with Patient-Focused Warming Strategies. Our objectives for today are to explain the benefits of pre-warming to prevent hypothermia, identify the significance of cutaneous heat loss and measures for prevention, discuss perioperative patient temperature management risk categories that can contribute to postoperative hypothermia, list typical warming measures and their contributions to cutaneous warming, and lastly, describe steps to implement a patient-focused warming strategy that uses the most effective measure or combination of measures available to preserve cutaneous heat. Our initial Mind the Gap education focused on understanding the shift in the patient population from inpatient to outpatient and addressing the needs of patients undergoing shorter duration procedures. This education moves deeper into the challenges associated with effective temperature management for the patient. Although it may seem a simple problem, we have found it to be anything but that. Recommended practices for the prevention of perioperative hypothermia, including AORN and ASPEN guidelines, identify normothermia as a core temperature range of 36 degrees Celsius to 38 degrees Celsius. We'll start our discussion where the patient and first opportunity for prevention begin, the preoperative environment. This diagram illustrates how typical heat loss occurs preoperatively. According to a 2010 study by Leith et al., most patients arrive in the pre-op area normothermic. The top row of figures shows the patient arriving normothermic and immediately beginning to lose heat during prep and transport. Without early intervention, the patient can arrive in the OR hypothermic and compromised. In contrast, the lower portion of the diagram shows how prewarming or banking heat allows the patient to arrive at the OR normothermic. When a patient arrives in the OR in a hypothermic status, it can be difficult and sometimes impossible to restore normothermia before transport to PACU. The responsibility for maintaining perioperative normothermia generally belongs to the operating room, anesthesia, or postoperative care teams. Sophia Miko-Shield explains in her CE course, nurses in each area of the perioperative setting can influence patient outcomes. Nurses can have a positive impact in the preoperative holding area during admission, in the OR during surgery, and in the PACU with recovering patients. None of the settings are islands to themselves, but rather they affect patient outcomes and the total continuum of care. We should strive to maintain the patient's warmth to ensure they maintain normothermia. Following recommended protocols, including pre-warming interventions, can help improve patient outcomes. To bring this more into focus, let's review how the anesthetized patient loses heat. Redistribution temperature drop is the primary cause of unintended perioperative hypothermia and is responsible for up to 81% of the total decrease in temperature within the first hour. Redistribution temperature drop, or RTD, occurs during the first hour immediately following anesthesia induction and results in a decrease in body temperature occurring as heat is exchanged from the body's core compartment to the peripheral tissues. At this point, the body loses heat through four mechanisms, the largest contributors being radiation and convection, which account for 70% of the total heat loss. Therefore, protecting the patient from heat loss due to radiation and convection is essential to minimize the impact of RTD. Relevant to this, Sessler states in his perioperative thermal manipulations text in Miller's Anesthesia, cutaneous heat loss is roughly proportional to surface area throughout the body. Consequently, the amount of skin covered is more important than which surfaces are insulated. It does not make sense to cover the head and leave the arms exposed because the arms have more surface area than the head and account for more heat loss. He continues to say, the easiest method of decreasing cutaneous heat loss is to apply passive insulation to the skin surface. Passive insulation can be accomplished with reflective warming measures, which warm the skin surface and reduce heat loss due to radiation and convection. Now that we've reviewed how heat is lost, we'll take a look at some factors that contribute to overall risk assessment. When assessing risk, we need to understand that all patients are at risk and therefore need to be protected. For the purposes of this education, we've identified three key risk categories, which include the patient, the procedure, and the environment. Each of these has contributing factors that can impact the overall risk for a particular patient. For example, a patient-related risk is their body weight. Procedure-related risks include the duration, with a cold surgical environment contributing to environmental risk. The CDC National Center for Health Statistics reported 79.4 million surgical procedures were performed in the U.S. during 2006. Based on the findings of Muller and Lockwood in 2011, 50 to 90% of patients experienced unplanned perioperative hypothermia. Conservatively speaking, that means that patients undergoing 39.7 million procedures were impacted despite aggressive patient warming protocols. Patient warming strategies do not come in a one-size-fits-all package. Each patient should be evaluated for the strategy that best meets their particular needs. According to the article, Keeping Patients Warm Throughout Surgery by Sherry Burns, the secret to making sure your patients stay warm is to combine measures to maintain body temperature from the time patients enter your facility through discharge. This offers the greatest likelihood of minimizing body temperature change and maximizing comfort in surgical patients. Protecting patients is a proactive choice and should begin as soon as they arrive in the preoperative area. Once they become hypothermic, they are exposed to a higher risk of associated adverse outcomes. A landmark study in the May 1996 issue of the New England Journal of Medicine first identified the relationship of hypothermia to postoperative infections, and here we are 19 years later still facing this challenge. Prevention is better than a cure. If we can maintain the patient's temperature throughout the perioperative process, it is far more beneficial to their experience and less likely that more aggressive warming measures will be needed to raise the patient's temperature subsequently. Pre-warming patients with reflective warming products which warm the skin surface and reduce cutaneous heat loss is an important preventative measure to consider. This graph illustrates the outcomes of a study performed at Erasmus Medical Center in the Netherlands, where the implementation of pre-warming with heat-reflective gowns was beneficial to the patient. The study included a total of 60 patients undergoing orthopedic surgery for the duration of 15 to 90 minutes of actual surgery time. The control and subject groups each contained 30 patients. The control group was issued a standard hospital gown, and the subject group was issued a heat-reflective gown. As shown, both groups were normothermic upon admission and demonstrated a temperature increase upon arrival to holding. The heat-reflective gown group maintained the initial increase in average temperature through PACU. Additionally, there was an increase in patient temperature at discharge with no additional warming measures required. However, the average temperature of the control group with the cotton patient gown decreased from 36.3 to 35.7 Celsius upon arrival to PACU. In addition, 16 of the 30 patients in the control group required active thermal management to achieve an average temperature of 36.1 degrees Celsius. Evidence demonstrates prevention is better than a cure. Therefore, we need to bank the patient's heat. According to ARN recommended practices, patients should be pre-warmed prior to induction of anesthesia for a minimum of 15 to 30 minutes, also known as banking heat. Specifically, warming the patient's skin and peripheral tissues before induction of general or major regional anesthesia prevents redistribution hypothermia. The temperature of the peripheral tissues is increased and vasodilatation triggered. This results in a smaller core to periphery temperature gradient and minimizes the effect of anesthesia-induced vasodilatation. AORN recommendations include implementing passive thermal care measures such as reflective warming preoperatively. The illustration on the left depicts a typical patient without pre-warming. The warm core blood has moved to the periphery, picking up cooler blood and decreasing the core temperature. Once the core heat shifts to the periphery, it is lost through the surface of the skin, which is also illustrated by the blue line figure. On the right, the patient's heat has been banked through pre-warming the skin surface with reflective warming, allowing the core temperature as well as the periphery to remain stable and the patient to arrive normothermic into the OR. SCIP INF10 propelled us to take the first step in facing the challenge of patient temperature management. It targeted procedures with an anesthesia time of 60 minutes or longer. This is an important fact to keep in mind. Compliance for this measure required one of these three boxes to be checked. It did not require normothermia be achieved, just aggressively pursued. This measure has since been deemed topped out and was retired as of January 2014. This means that nearly all hospitals have achieved a similar high level of performance on these measures. According to Sappenfeld et al., merely complying with the Surgical Care Improvement Project measurement is inadequate for optimizing perioperative outcomes. SCIP INF10 being topped out does not mean that 100% of patients achieved normothermia. Furthermore, AORN states hospitals must be responsible for updating policies and educating staff in response to topped-out measures. Lividus defined topped out as there was no meaningful difference in performance between providers and little opportunity for further improvement. However, the prevention of hypothermia must still continue as a priority for all patients. As seen in the chart on the right, the 2006 data provided by the CDC Health Statistics Report reported the majority of surgical procedures, 47.2 million, were performed on an outpatient basis. These procedures had a median OR time of 50 minutes. We established this patient population in our earlier course as the GAP. We've made progress, but we still have work to do. Despite an increased awareness and more robust patient warming protocols, we continue to see a significant number of patients delivered to the PACU hypothermic. The 2012 study by Lewis et al. Revealed 32% of patients are hypothermic upon arrival to PACU, including those using forced air warming. The number of patients affected is clearly significant and demonstrates there's still far too many patients in the gap. The 15.1 million outpatient and 10.3 million inpatient procedures in this demographic need improved patient warming strategies. To see a significant change, we should implement the most effective measure or combination of measures to proactively address the needs of all patients. There are many warming measures to choose from, so let's examine the differences. The difference can be made by selecting the right warming measure or combination of measures at the right time. Traditional linens and apparel are common staples in the perioperative environment. They serve the basic functions of comfort and modesty, but provide little or no therapeutic benefit. As demonstrated in the study by Sessler and Schroeder, cotton bath blankets only provide temporary comfort for the patient, and the warming benefits are minimal and relatively short-lived. In fact, warming dissipates in less than 10 minutes. Forced air is one of the most common active warming measures used intraoperatively. This technology is now available in the preoperative environment as a warming gown. Although it is recommended these products be activated during pre-op, since it is a comfort-focused system, therapy is controlled by patient preference. This can then present the opportunity for pre-warming benefits to be minimized. Additionally, when the gowns are used as an upper body blanket intraoperatively, the majority of the skin remains exposed and unprotected. A 15-month study published by Lichens et al. In June 2013 showed 26.3% to 28% of patients using forced air warming developed perioperative hypothermia. Reflective warming products combine the function of traditional linen with intrinsic warming and insulating properties. When used preoperatively, they warm the skin surface and bank the patient's heat. They are more effective and efficient than traditional linens. In addition, laboratory testing demonstrates when reflective and forced air warming products are used as a combined measure, the efficacy of forced air warming can be improved up to 15%. We need to make every minute count, and a simple algorithm or decision tree like this can help. According to Roth, without pre-warming, there may not be enough time for intraoperative active warming to be fully effective. This can result in reduced comfort, increased pain, and increased nursing time, as well as the need for additional warming interventions. This decision tree demonstrates a recommended practice guideline for reflective warming products. It provides guidance for each area of care. In short duration procedures, typically 90 minutes or less, passive measures such as reflective warming begin to work immediately to bank heat and to promote normothermia perioperatively. For longer duration procedures and/or for patients who arrive hypothermic, active warming measures may need to be added to the strategy to supply an external source of heat and regain normothermia. Again, applying the right measure or combined measures the right way at the right time is paramount. As previously stated by Sherry Burns in Keeping Patients Warm Throughout Surgery, the secret to making sure your patients stay warm is to combine measures to maintain body temperature. Protecting patients is a proactive choice and should begin as soon as they arrive in the preoperative area. When selecting a temperature management strategy, it is important to understand the role of skin surface warming and cutaneous heat loss. According to the Cleveland Clinic Center for Continuing Education, roughly 90% of metabolic heat is lost through the skin surface. Maximizing skin coverage early and maintaining it throughout the perioperative journey helps preserve and bank cutaneous heat. The rule of nines divides the body's skin surface into sections, each with a value relative to total body surface area. As illustrated, the smaller surface areas include the head and arms, each of which contain 9% of the total body surface area. The larger areas, which each contain 18% of the skin surface, include the upper and lower torso, as well as the legs. Finally, let's take a look at a typical product application tool to see how using the rule of nines can help in selecting the most effective measure or combination of measures to preserve and prevent cutaneous heat loss. Color-coded product application charts, like the one pictured here, establish guidelines that can serve as a simple reminder and quick reference for product selection and application. For instance, covering the upper body during an abdominal procedure, which is common when using forced air warming products, addresses approximately 36% of the skin surface. Simply combining measures such as adding reflective warming products, such as a cap and a lower body blanket, cover an additional 45% of the skin surface. This combination of measures maximizes skin surface coverage and protects 81% of the skin surface. Use of this type of tool can help drive compliance by providing specific recommendations for skin surface coverage. In summary, we've discussed why pre-warming is so essential to effective patient temperature management, looked at the impact of redistribution temperature drop on cutaneous heat loss, the importance of assessing each patient, and the need for continued efforts to improve patient outcomes. We've all heard it takes a village. We believe our village is the perioperative environment, and we all share responsibility to achieve our goal of patient normothermia. Thank you so much for attending today's presentation.
Thank you so much, Carol. Fantastic presentation. We do have some great questions that we've been coming in. The first one is, in your opinion, what is the easiest method of decreasing cutaneous heat loss?
It has been demonstrated that applying passive insulation to the skin surface is the easiest method of doing that. And passive insulation can be accomplished by the use of reflective warming products.
Okay, great. We have another one here, and please forgive me if I butcher any of these really long medical terms. How is modality maintained through pre-op / intra-op and post-op achieved? Our facility struggles with temporal pre-op esophageal or nasopharyngeal intra-op and temporal in PACU.
And I think what the individual is asking is relative to temperature management and monitoring the patient's temperature. And if I'm not addressing their question as needed, please tell me. Using the products can be placed on initially in the preoperative environment, the reflective warming products that we reference. Those products can travel with the patient to the OR, and as long as they are not interfering with the surgical field, can remain on the patient during the surgery. They can be positioned obviously away from the surgical field. And if the patient also is requiring active warming measures, then they will be positioned away from those active warming measures, but still help to cover the total skin surface of the body. Depending on the hospital's procedure, policies and procedures would determine which method they use to monitor the patient's temperature. Did that answer the individual's question?
I believe so. They can certainly email us again if they did not. And that's just a reminder, everybody, we are taking questions right now for Carol. If you have any questions, please feel free to go ahead and ask them. This next question comes in, and it says, how long should patients at risk of unplanned hypothermia be pre-warmed prior to induction of anesthesia?
For a minimum of 15 minutes. We have found if they can be pre-warmed for up to 30 minutes, it's even more beneficial to the patient. However, for a minimum of 15 minutes.
Okay, and I think this might be a follow-up to the number 2 question. Modality, meaning how temperature is taken?
I believe that individual may be referring to that. We don't recommend how a temperature should be taken. We believe that should be the decision of the surgeon and the facility.
Okay, great. I think that wraps up all the questions that came in. If there's any others, please feel free to do them right now. Otherwise, thank you, Carol, so much for taking the time and your wisdom you shared today. Again, OR Today would like to thank today's sponsor, Encompass Group. Please visit www.encompassgroup.net to learn more. Attendees, remember, to obtain your certificate of attendance, you must complete the post-webinar survey at the conclusion of today's presentation. This survey will appear immediately on your computer screen. Certificates will be emailed on or before June 25th. If you do not receive the survey, please email us at webinar@mdpublishing.com. As a special bonus today, we are going to be giving away our I Heart OR bumper stickers for all the people that complete the survey. Please visit ortoday.com/webinars to register for the next OR Today webinar, which will be on July the 16th. Again, thank you, Carol. We appreciate your help, and everyone have a great rest of the day.
Thank you, everyone.